People who know me know that I'm very fond of saying that my skilled buildings are the best in the country. Not because I think so, because we've been ranked 4 and 5 stars by the Secretary of CMS. We've been noted as being best nursing homes by U.S. News and World Report. And the American Healthcare Association granted us recognition at the gold level of the Quality Award Program. But things have changed since March 2010. The Affordable Care Act was billed as insuring those who are uninsured. But the reality is, it also changed delivery reform, integrated care networks, quality, and innovation. One of the innovations was to use EHRs. I wondered, we have an EHR, but how much of my patient chart do I really see? Nurses' aides, registered nurses, nurse practitioners, doctors, medical directors are all putting information into our medical chart. But we don't know what we're really seeing. We don't know that the patient's conditions are changing. Enter real-time medical systems. I want you to think of real-time as an app. It is not an EHR. It works on top of an electronic record. And what it does is it gives us information the way Google Waze gives you information if you're using it. Waze gives you incidents, accidents, police, construction. This is going to tell us about changing patient conditions. It's going to assess the staff documentation accuracy. It's going to recognize care improvements for us to change our care plans, all getting information from our EHR. In addition to that, they've got a great feature that gives us a predictability index for a patient going back to the hospital. Readmissions is not a good thing. It costs a lot of money. It also gives us updates on quality measures, and it makes us a better partner with accountable care organizations and preferred provider networks, giving us more information so that we can treat our patients better in our facilities. Now, it's driven on dashboards, clinical dashboards, financial dashboards, and something they call proactive. Today, we're going to go through 2 clinical dashboards and 2 financial dashboards. We're going to see alerts by category, quality measures, we're going to look at readmissions, and we're going to look at rug distribution. If I click on this segment here, this shows me that Wayne has lost weight. Losing weight's not a good thing in a nursing home. He may not like the food, that might be one thing, but he also may have some serious conditions. So what do you do about it if you're losing weight? Off to the right here, what you're going to see is suggested interventions. These interventions are coming from the American Medical Directors Association and the Interact 4 protocol. Highly respected organizations. These are tried and true interventions. If you've got other ones that you want to customize, you can put them in here. Your facility may have a better way of treating patients, but this is very helpful. Admissions are a 4-letter word in our industry. CARD is a 4-letter acronym that Real-Time has put together. Clinical alerts, admission recency, readmits back to the hospital, and diagnoses. They take these elements, they create a CARD score. Here, Leanne has a CARD score of total of 11. In our shop, we start to pay attention at 5. At 10, we put this under a microscope, trying to figure out why this is going on. Because we know that hospitals are getting penalized when we send them back to the hospital. That's not a good thing. We send fewer people back to the hospital, we get more admissions. This past year, 2018 to 2017, we have increased admissions 13% at one of my buildings. Every single referral source has increased their admissions back to us because we're sending fewer people back to them. That's dollars in their pocket. The next measure that we're looking at is quality measures. Quality measures are important. These are things like intake, outtake, behavior, falls, bowel movements, things that affect the quality of a patient's healthcare. But it also does something else. In a way of a stoplight, green, yellow, and red, it'll highlight what quality measures are being triggered and whether the patient is a long-stay patient or a short-term patient. For those of us in the business, we know that quality measures are a big deal because they affect our 5-star. 5-star is based on survey, staffing, and quality measures. If we can make these quality measures better before they get to the MDS, before they get to the patient assessment form, we have a better opportunity to increase the score for our quality measure, which helps us with our overall 5-star quality. In Connecticut, if you are a 3, 2, or 1 star, you are not in anybody's network. So working hard to keep quality measures up is good. Illogical coding. This is staff putting a code in that's contrary to what a nursing assessment has. We've analyzed this with real-time help, and we have determined that we've increased our Medicare 4% a year, $16 per patient day. Doesn't sound like very much, right? How does $250,000 a year sound? That starts to ring some bells. That's cash flow. You can do a lot more with that. This is another way of looking at illogical coding. In our patient assessment, we look at ADLs, bed mobility, transferring, eating, and toileting. If these two measures are different, that means that the nurse's aide put something in differently than the nurse. This is my most favorite one. This is illogical coding. Lower is better. If you click on this dot, it gives us a list of all of our staff. If you click to the plus sign here, it'll show every patient in every ADL that was illogically coded. This tells me I need to go back and train staff. Finally, our clinical results have been proved. Maintaining a 5-star rating is not easy. It takes diligence and all the granular detail you can possibly get. We have been 5 and 4 stars since the inception of the program. In the last couple of years, real-time has helped us. Financial results. Quality is the new currency. If you haven't picked up on that yet, you still have an opportunity. Real-time can help you. Better management of unnecessary readmissions. You saw that we managed them better. We were getting 13% more admissions at one of my buildings. That's cash flow into us. It's cash flow into the hospital. Finally, just like in 1984 when Apple challenged IBM's legacy, real-time is challenging how we all use our electronic health records. If you're a provider, this is a game changer. If you're a lender, right next to the debt service coverage covenant, you need to have this as a covenant. Your borrowers need to be getting better. Thank you very much.